Welcome. I'm Dr. Robert Parisian. I'm an orthopedic sports medicine surgeon and associate professor at the Icahn School of Medicine at Mount Sinai in New York City. And this evening, we're here to talk about orthobiologics and regenerative treatment of rotator cuff tears. This is not going to be a technique focused talk. This rather is going to be looking at evaluating and critically examining the evidence behind orthobiologics as far as rotator cuff tears and pathology are concerned. My disclosures are as so. For the AAOS, I'm on the Sports Medicine Evaluation Committee. So rotator cuff repair failure, let's look at the epidemiology quickly so we know what we're dealing with. Overall prevalence of tears, very common in the United States, estimated 7 to 26% of the population, and really as much as 50% in those over the age of 80 years. There's about 270,000 rotator cuff repair surgeries that's performed annually in the United States. Then here are our failure rates. And so, once we critically look at the evidence, we realize that, we sometimes aren't as good as we need to be for our patients. And so medium tears, 1 to 3 centimeters, the failure rates are about 20%. And then very high failure rates for those massive tears greater than 3 centimeters. Now, looking at revision surgery, about 8 to 10% of the primary repairs that fail will go on to have a revision surgery. And then those surgeries themselves have a high failure rate as well. So orthobiologics, the topic of our discussion this evening. What are the options? And so we will discuss corticosteroid, and although it's not typical orthobiologic management, we will also discuss bone marrow stimulation via subcondylar drilling or microfracture, utilization of hyaluronic acid, and rotator cuff tear pathology, PRP, bone marrow-derived mesenchymal stem cells, microfragmented adipose tissue, as well as the combination of the two. Now, we need to look at what is FDA approved in the United States. There are no FDA approved stem cells, although adipose-derived and bone marrow-derived do have stem cells within them. We need to have no stem cells are FDA approved currently in the United States for the treatment of rotator cuff tear pathology. And that's what I remind our patients of. And so here's a summary of the FDA classification and regulatory oversight for orthobiologics, categories 1, 2, and 3. And really the lowest risk product you'll see here in category 1 is PRP and adipose-derived or bone marrow aspirate, concentrate, and fat grass. As you get up into category 2 and category 3, these are also FDA approved, but there are other regulatory environments that are required. So products in the first group, those are considered to be low risk, although still regulated as human cells, tissues, and cellular or tissue-based products. They do not require pre-market approval or a biologics license application. These examples, as I said, are whole blood, blood-derived products, bone marrow, human organs. These biologic agents must only be minimally manipulated, and that is why they're in category 1. They use in a homologous fashion, and they're not combined with any other agents. Again, PRP, bone marrow aspirate are the most common, and category 2, adipose-derived, are all minimally manipulated and are FDA approved. So let's look at corticosteroid initially and for the management of tendinopathy. We'll discuss tendinopathies, then we'll get into rotator cuff tear pathology. So this study evaluated corticosteroid injections as compared to physical therapy interventions when looking at tendinopathy. Systematic review and meta-analysis. They looked at 15 randomized trials, so nearly 2,000 patients in this meta-analysis. And what did they conclude? Well, corticosteroid injections seem not to be superior to physical therapy injections, other than resulting in some transient improvement at short-term outcome provided physical therapy intervention. So corticosteroids can provide short-term pain management solutions in these patients with tendinopathy, but overall not superior to physical therapy. Now, preoperative utilization of corticosteroid, and how is that put our patients at risk for a surgical site infection who undergo an arthroscopic rotator cuff repair? Well, this is a nice study that evaluated this. There's a Pearl Diver database, so it does its limitations as a typical database would. However, they have access to a large amount of patients. So patients are stratified into 2 cohorts, those that underwent arthroscopic repair within 1 year of the injection, and then those that underwent arthroscopic rotator cuff repair without prior injection. And what did they conclude? Well, the injections that were within 1 month of the arthroscopic rotator cuff repair significantly increased the risk of surgical site infection. There is no increased risk of infection of the surgical procedure if it's delayed by greater than a month. So, it's corticosteroid injection within 1 month prior to your arthroscopic procedure significantly increased the risk of infection. So that's why I typically wait at least greater than a month from a corticosteroid injection before proceeding. Another study that supported this, this was an insurance database study. They used to determine all patients who underwent shoulder arthroscopy for a 5-year period with an associated preoperative corticosteroid injection. They found similar results that the study showed the postoperative infection risk is greatest when the corticosteroid injection was given within 2 weeks of the shoulder arthroscopy. And so they stated the risk of postoperative infection is not significantly increased when corticosteroids are given more than a month before surgery. So again, a recommendation of corticosteroid injection at least greater than a month prior to your arthroscopic rotator cuff repair surgery. Now, what about intraoperative corticosteroid injections? Is this a risk for infection? So this study looked at a total of 530,000 patients. Again, another Pearl Diver database study that allows us to have a large number. Especially when looking at infections, this is important, and databases are very helpful in this manner. They concluded that an intraoperative corticosteroid injection was a significant independent risk factor for postoperative infection after shoulder arthroscopy. So do not recommend intraoperative corticosteroid injections while doing rotator cuff repair. What about a postoperative corticosteroid injection? Again, looking at a private payer and Medicare database, this study evaluated nearly 4,000 patients. They found the patients who underwent a corticosteroid injection within 1 month, again, postoperatively, so after the arthroscopic rotator cuff repair, had significantly higher rates of infection. So those that underwent corticosteroid injection within 1 month prior, or corticosteroid injection intraoperatively, or a corticosteroid injection at 1 month, within 1 month postoperatively, all had increased rates of infection. Now, looking at outcomes of corticosteroid injections, they may increase your retear and your revision rates. So the results of this study that looked at 11 studies, including over 176,000 shoulders, found that corticosteroid injections provide benefit by relieving pain and improving functional outcome scores, as we would expect. However, repeated preoperative steroid injections may actually increase your retear rates and your likelihood of a revision surgery following your rotator cuff repair if you had multiple preoperative corticosteroid injections. So yes, they provide short-term pain relief and pain management, as well as some functional increase because of that decreased pain management. But if you proceed with a rotator cuff repair surgery after many multiple corticosteroid injections, you may have increased retear rates and revision surgery. Now, what do the AAOS practice guidelines tell us? Now, the most updated practice guidelines for rotator cuff repair are in 2019. There is moderate evidence in support of a single injection of corticosteroid with local anesthetic for short-term improvement of both pain management and functions with shoulder pain. So important to know what our AOS CPGs are telling us. Now, looking at bone marrow stimulation, this is marrow venting at the area of the greater tuberosity footprint for supraspinatus and infraspinatus. So this involves perforating the cortical bone either via subchondral drilling or microfracture that allow the egress of marrow elements. This study evaluated bone channeling and arthroscopic rotator cuff repair as a systematic review and meta-analysis of level 1 studies. They looked at 6 randomized trials, an N of 593. And what did they find? Well, this meta-analysis of level 1 evidence demonstrates that bone marrow stimulation in the setting of primary arthroscopic rotator cuff repair has no significant effect and no benefit on functional outcomes, healing, pain, or reoperation rates. So not recommended with regards to bone marrow stimulation at the greater tuberosity. Another study evaluating bone marrow venting at the greater tuberosity looked at 204 patients. They had small, medium, or large full thickness tears. They evaluated clinical and functional outcomes at 3 months, 6 months, 1 year, and 2 years after surgery. They evaluated tendon integrity also postoperatively via an ultrasound at 6 months and 2 years. What did they find with marrow stimulation and venting at the greater tuberosity? That there was no significant disparities in functional scores and clinical outcomes between the bone marrow group and the control group. No significant differences were observed between the vented group and the non-vented group. Now, hyaluronic acid, we utilize hyaluronic acid often for intra-articular injections, typically when treating for patients with osteoarthritis, but HA is a naturally occurring glycosaminoglycan found throughout the body. Some of the key elements of hyaluronic acid are its hydration and moisture retention, its viscoelasticity. It also has anti-inflammatory effects and may provide some structural support as a major component of the extracellular matrix. Now, looking at the role of hyaluronic acid when in tendinopathy, this is a study that evaluated the treatment effect of HA for soft tissue injections. They looked at 19 randomized controlled trials, over 1,500 patients in this cohort, and they found there was high heterogeneity present with rotator cuff tears and elbow tendinopathy. So mixed results with regards to hyaluronic acid utilization for tendinopathy. The AOS CPG guidelines, again from 2019, have limited strength of evidence. Recommendation is limited evidence in support of HA injections and the non-operative management of rotator cuff pathology. Now moving on to PRP. Platelet-rich plasma, which we're all very familiar with, is an autologous blood product consisting of plasma with increased concentration of platelets as compared to normal circulating blood. Now, PRP contains about 3 to 10 times more platelets than baseline blood and may contain variable concentrations of white cells, leukocyte-4 PRP versus leukocyte-rich PRP. And here's the basic process of which PRP is formulated. We have a blood draw of whole blood that is centrifuged. And again, this is considered minimally manipulated. So this is FDA approved as category 1. And then after the centrifugation, you have a red blood cell layer that is found in the bottom. You have a plasma layer, which is platelet poor plasma at the top. And in the middle there, you have your buffy coat, which is your platelet-rich plasma in your white blood cell layer. Now, leukocyte-rich versus leukocyte-poor PRP, it's important to know the difference and really understand when we're utilizing one and why we're utilizing one over the other. Leukocyte-rich PRP may have a higher than whole blood baseline. It is pro-inflammatory due to higher white blood cell content, whereas leukocyte-poor may have less of an inflammatory response without the white blood cells present. The growth factors in leukocyte-rich induce growth factor release, and leukocyte-poor may have a reduced inflammatory profile, as we said. Looking at tendinopathy, so PRP utilization in tendinopathy, this study evaluated 30 randomized controlled trials, about 2,500 participants in this study. And what did they find? Well, PRP provides significant short-term pain relief and functional improvements in rotator cuff tendinopathy. Another study looking and evaluating PRP for tendinopathy evaluated 50 patients. They were treated with one subacromial injection. And the results were that of the 32 patients who practiced sports before the injury, 84% returned to sports and 78% returned to the same level of sport. Again, those patients that received a subacromial PRP injection. So subacromial injections of leukocyte-rich PRP significantly decreased the pain, improved functional outcomes, and resolved the sleep disturbances as found in this study of 50 patients undergoing subacromial PRP injection for tendinopathy. Clinical practice guidelines by the AAOS have, again, a strength of recommendation is limited for PRP utilization for tendinopathy or partial tears. But again, the latest guidelines are in 2019. And as you have seen, we have a few studies that are out that are demonstrating benefit of PRP for tendinopathy. Now, what about PRP as an adjuvant to rotator cuff repair surgery? This is a nice study that evaluated, or a nice review, a meta-analysis that evaluated 17 studies. The re-tear rate for the treatment group they found was 19% as compared to the control group of 25%. So again, the treatment group, so rotator cuff repair with adjuvant PRP, re-tear rate was 19% versus those who did not receive PRP at 25%. This was statistically significant. So overall, the treatment with the PRP significantly improved constant scores, as well as VAS scores and SST scores. So a benefit with PRP as an adjuvant Another double-blind randomized controlled trial, very well done study with 96 consecutive patients found that the re-tear rate in the PRP group was 15%, which was lower than that of the control group at 34%. So again, the control group that did not receive PRP injection at the time of rotator cuff arthroscopic repair surgery had a re-tear rate of 34% as compared to only 15% re-tear group in the PRP group. So the authors of this study concluded that in patients with rotator cuff tears less than 3 centimeters undergoing a double row suture bridge repair, a 5 milliliter dose of leukocyte pore in this study, leukocyte pore PRP, injected in the tendon bone interface significantly reduced the re-tear rate. So leukocyte pore PRP injected at the tendon bone interface. Now, this is a excellent study that evaluated, again, arthroscopic rotator cuff repair and adjuvant rotator cuff repair with adjuvant PRP. Now, meta-analysis of randomized controlled trials evaluated 21 RCTs. And so when we look at the literature, and if you're wondering if there's enough data out there, there is plenty of data that has evaluated PRP as an adjuvant in rotator cuff repair surgery. This meta-analysis of 21 RCTs had nearly 1,500 patients, and the results, they found significant results were noted in favor of the PRP treatment group compared with controls based on re-tear rates of 16% versus 23%. So again, the control group had a re-tear rate of 23.6%, whereas the PRP injection group had an re-tear rate of just 16.5%. So they concluded that intraoperative use of PRP reduces the risk of rotator cuff repair, improves clinical outcomes, and reduces recurrence rates. Now let's move on to bone marrow-derived mesenchymal stem cells. So this is Slick Willie Sutton. Willie Sutton was a bank robber. And Willie Sutton is famously asked, why did you rob banks? And his response was, well, because that is where the money is. And so where is the money for bone marrow aspirate concentrate? This is a nice study that's quantitative assessment of the optimal marrow site for harvesting bone marrow aspirate derived mesenchymal stem cells. And they found that all anatomic bone marrow sites contained MSCs. However, the iliac crest was the most abundant source for MSCs. So for me, in my practice, my go-to for harvesting of bone marrow-derived mesenchymal stem cells is certainly the iliac crest. This is the prospective randomized trial of biologic augmentation with bone marrow aspirate concentrate on patients undergoing arthroscopic rotator cuff repair. The purpose was to compare the outcomes of rotator cuff repair with or without concentrated bone marrow aspirate. They evaluated 91 patients that were enrolled in the study, 45 in the aspirate group and 46 in the control group, or rather 45 in the control group, 46 in the aspirate group. And what did they find? They found that the control group showed significantly greater evidence of rotator cuff re-tear, according to the Sagaya classification, at 1 year MRI. So the control group re-tear rate on MRI at 1 year, 57%. The bone marrow aspirate concentrate re-tear rate on MRI at 1 year, just 18%. So a significant benefit in this patient group of 91 patients with bone marrow aspirate concentrate injection at the time of rotator cuff repair surgery. Another great study looking at bone marrow aspirate concentrate or bone marrow derived mesenchymal stem cell augmentation during rotator cuff repair evaluated 45 patients who received bone marrow derived MSCs. They compared to those of a matched control group of 45 patients. What did they find? 100% of the 45 repairs with the MSC augmentation had healed by 6 months versus just 67% of the 45 repairs without the augmentation. So again, evaluation at 6 months, 100% of those who had MSC augmentation had healed. Now, this was a wonderful study that went and looked at 10-year outcomes and 10-year data, and at their most recent follow-up at 10 years, intact rotator cuffs were found in 87% of the MSC treated group. 87% of those patients that underwent bone marrow-derived mesenchymal stem cell adjuvant therapy at the time of the rotator cuff repair had intact rotator cuffs at 10 years. Whereas in the control group that did not receive bone marrow derived mesenchymal stem cell management, only 44% of those patients had intact rotator cuffs at 10 years. So significant improvement and benefit for bone marrow derived adjuvant therapy at the time of arthroscopic rotator cuff repair. Now, as we touched upon at the beginning of the talk, microfragmented adipose tissue, which is, again, FDA approved. This adipose tissue provides distinct advantages as a source of mesenchymal stem cells due to its accessibility and the ease of isolating these stem cells. Now, human adipose stem cells located in the stromal vascular fraction can be harvested using mechanical methods. Then local injections of the microfragmented adipose tissue have shown potential in promoting natural tissue regeneration. So how do they perform when utilized for rotator cuff repair? Well, the hypothesis of this study was that microfragmented paracrine action would reduce the catabolic and inflammatory marker expression in tendon cells derived from injured supraspinatus tendon. And so they were looking at really the impact of the microfragmented adipose tissue on catabolic and inflammatory markers. And what did they find? Well, they found that the microfragmented adipose tissue had an anti-inflammatory effect on the supraspinatus tendon cells in vitro through paracrine action, resulting in the reduction of both catabolic and inflammatory marker expression. And then they concluded these observations potentially support the use of microfragmented adipose as an adjuvant therapy in the treatment of rotator cuff disease. So a very interesting study is published in 2020. Now looking at microfragmented adipose tissue, this is really the one major study that is in the literature at present. The purpose was to evaluate the safety and efficacy of autologous lipoaspirate tissue in arthroscopic rotator cuff repair surgery with 2-year follow-up. So again, 44 patients, 22 in the control group and 22 in the treatment group with a minimum of 2-year follow-up. They concluded that this prospective randomized controlled trial, high-level evidence trial, demonstrated that the intraoperative injection of autologous microfragmented adipose tissue is safe and effective in improving short-term clinical and functional results after a single arthroscopic rotator cuff repair. So a well-done level 1 study evaluating microfragmented adipose tissue as an adjuvant to rotator cuff repair, but more data is needed on this topic as we do not have any studies currently in the literature. Now, what about bone marrow aspirate, the bone marrow derived mesenchymal stem cells and PRP synergistically as an adjuvant for rotator cuff tendon repair? So this study was to investigate the effect of the BMAC and PRP synergistic effect on the tendon-derived stem cells and to find a therapeutic effect of the BMAC PRP on rotator cuff tendon tears. What did they find? That their data from this evaluation indicated that bone marrow aspirate concentrate and PRP together enhanced the proliferation and migration of tendon-derived stem cells and prevented the aberrant chondrogenic and osteogenic differentiation of these tendon-derived stem cells, which then might provide a mechanistic basis for the therapeutic benefits of a synergistic BMAC and PRP utilization in rotator cuff tendon tears. So an evaluation of the evidence and critical assessment, looking at orthobiologics as well as hyaluronic acid and corticosteroid injections, what are the final thoughts and recommendations and take-home points from the evaluation of our current literature? Well, corticosteroid injection administered less than 1 month prior to rotator cuff repair surgery significantly increases the risk of infection, so is not recommended. Intraoperative corticosteroid injection significantly increases the risk of infection in shoulder arthroscopy. Corticosteroid injection less than 1 month following an arthroscopic rotator cuff repair significantly increases your risk of infection. So corticosteroid injection should not be utilized within that peri 1 month period and should not be utilized intraoperatively with shoulder arthroscopy and rotator cuff repair surgery. Looking at bone marrow stimulation, it has no positive impact on tendon integrity, pain and healing rates, as well as clinical outcomes compared to not marrow venting the greater tuberosity footprint. There is also no clear role for hyaluronic acid when it comes to rotator cuff tendinopathy management. Now, PRP may provide improved pain, clinical outcomes, sleep quality, and return to sport rates in rotator cuff tendinopathy management from the current literature. Now, when you think about PRP as an adjuvant to arthroscopic rotator cuff repair surgery injected at the tendon to bone interface, this may reduce re-tear rates and improve clinical outcomes from the many randomized controlled trials and meta-analyses that we have looking at this topic. As far as microfragmented adipose tissue injected at the tendon bone interface, this may reduce re-tear rates and improve clinical outcomes, but as we stated, there's not a lot of evidence and studies on this topic, so certainly more clinical data is needed regarding microfragmented adipose tissue. An evaluation of the synergy of bone marrow derived mesenchymal stem cells and PRP. This has a proven mechanistic basis for therapeutic benefit in rotator cuff tendon healing, but clearly more clinical data is needed with regards to the synergistic effect of mesenchymal derived stem cells from bone marrow and PRP. And finally, an updated AAOS CPG to include recommendations on orthobiologic adjuvant therapy, as we do have recommendations for tendinopathy, but we don't have current updated recommendations, with the last being in 2019 for orthobiologic adjuvant therapy in arthroscopic rotator cuff repair. So thank you for your time this evening.